Well, this year's ASH, I think, is characterized in particular by the reporting out of the first combination phase 3 studies in myelofibrosis, both with Navitoclax and Ruxolitinib versus Ruxolitinib alone, and Ruxolitinib and Pelabresib versus just Ruxolitinib alone. And for many years, there have been, I would guess, at least 40 different combination studies done in the phase 2 setting for myelofibrosis. And the reason that most of those had not progressed to a phase 3 study is that it was very difficult to clearly differentiate from the impact of Ruxolitinib alone versus the addition of a secondary agent. In both of these studies, what's reported at this year's ASH is that the combination is dramatically better for the reduction of splenomegaly, with each of these having almost a doubling of the formal spleen volume response for combination over single agent Ruxolitinib. I think this will be important. I think this may make a difference in terms of the duration of disease control, the potential impact on survival, other factors of disease modification. Additionally, there were several important secondary endpoints that I think will further mature. First, in terms of symptoms. In both cases, symptoms were similar to slightly better with the combination. The studies had a pre-specified endpoints of being superior for total symptom score. I think that neither of them met that particular analysis. However, I think that there's limitations to looking at this strictly from a total symptom score perspective. I think the absolute change, as well as really not having any loss in that symptom response by combination therapy, is also very relevant. Here we're doubling down on the spleen response, maybe having a more aggressive impact against the disease. You know, we're not trading that off for an increase in toxicity or a loss of symptom response. Was it realistic to expect, clear superiority over JAK inhibition alone for symptom improvement? It may have been overly ambitious, and may not be necessary for biological benefit for both of these things to necessarily have been superior. So I think there's going to generate a lot of discussion, but I view them as very positive studies, as we continue to mature as a field, really from now a mature period of 4 approved single-agent JAK inhibitors, Ruxolitinib, Fedratinib, Pacritinib, and Momelotinib, and now really evolved to an era of more combination therapies.